Okay, good morning.
Good morning.
So this lecture was entitled An Overview, and I wasn't quite sure what we were supposed to overview, so we'll do pediatric palliative care. So I'm going to split this lecture into two parts, and the first part we'll go through definitions, some patterns of childhood death, talk about who are the children who need palliative care and their dying trajectories. And then the second lecture will start with principles for pain and symptom management. Talk about necessary skill sets for pediatric palliative care. One needs to know how to assess symptoms in the young, the nonverbal, or the cognitively impaired child, and have experience with a spectrum of pain management techniques, symptom control, and basic knowledge of some common disease states, awareness of the child's understanding of the illness, which has to do with developmental pediatrics, communication skills, that one needs to feel comfortable talking to seriously ill children and their families, and obviously have a commitment to an interdisciplinary approach to these things. So, who are the children with life-threatening conditions who need palliative care? Life-threatening conditions for which curative treatment is feasible but may fail. Conditions with prolonged treatments which promote good quality of life but premature death is anticipated. Progressive conditions in which treatment is palliative at diagnosis but may go on for many years. And conditions of severe disability in which a premature death is anticipated. And if you think about some of the patients we've seen together on palliative care, most of them fall into one of these categories. Treatments designed to cure or prolong life and those aimed at comfort are not necessarily mutually exclusive. If you look at A there, one starts treating a disease state with active, aggressive intent, and then can go on to palliative intent, and finally death and bereavement. But if you look at it a different way, that you can actually combine palliative intent with active, aggressive intent just as easily. Whoops, sorry, I redid the slides here. Okay, so let's just talk about some situations in pediatrics where treatment, withholding or withdrawing treatment can be considered. The brain-dead child, and I'd like to digress a little bit in a minute and talk about brain death and specific requirements for eligibility of brain death in children. Persistent vegetative states, situations in which there is no chance, and I'll talk a little bit about that later. Situations in which there is no purpose to continuing treatment. If the situation is considered to be too burdensome or unbearable. Talk a little bit about brain death in children. The most common causes are trauma and anoxic encephalopathy. Other causes include infections, central nervous system, and neoplasms. A couple of prerequisites before declaring brain death in anyone. Either clinical or neuroimaging evidence of an acute CNS catastrophe has to be there. We want to exclude any complicating medical conditions that might interfere with the criteria. A patient can't be intoxicated or poisoned and has to have a body temperature, core temperature of more than 97 degrees F. Normal systolic blood pressure has to be 100. Of course, that may be age dependent. So a neurologic exam, which is probably the most important component, the patient has to be in coma, can't have any motor response. There can be no pupillary light reflex, and the pupil should be mid-position and dilated 4 to 9 millimeters. No corneal reflex, no oculovestibular reflexes, absent jaw jerk or gag reflex, absent cough with tracheal suctioning, absent sucking or rooting reflexes in the infant. Right, these are infant neonatal reflexes. You know what a rooting reflex is? Are you familiar with that? When you kind of stimulate the side of the mouth, the baby draws the head to the stimulus. And apnea as demonstrated by an apnea test. Okay. There's ancillary testing, electroencephalography, evoked potentials, both sensory and auditory. And then tests of brain blood flow, like angiography, Dopplers, MRAs, CT angios, and nuclear medicine studies, which can show you if there's any blood flow to the brain. Okay, in general, we never declare a baby brain dead before 7 days of age. In the age category of 2 months to 7 years, if we're going to do serial clinical examinations, we like them to be 48 hours apart, and for there to be 2 confirmatory ancillary tests from that list, that previous list. Okay. If the baby's 2 months to a year of age, that's the infancy period, we like to see the exam separated by at least 24 hours and 1 confirmatory ancillary test. In the 1 to 18 year age, it's the same pretty much as the adult. That is, the serial examinations can be separated by 12 hours. Although I think in the adults we may use even 6 hours. 2 exams 6 hours apart that are clinically suggestive of brain death. Okay, what about the no chance situation? Well, life-sustaining treatment may only delay death without any significant alleviation of suffering. And that's one of the situations where you might consider withholding or withdrawing. No purpose, the child may survive with treatment, but physical or mental impairments as a result would be so great as to be unreasonable to expect the patient to bear it. And finally, the unbearable situation, in where in the face of progressive and irreversible illness, further treatment is more than can be tolerated. Of course, while ethically withholding equals withdrawing may be a lot more emotional to bear. Talk a little bit about childhood death in America. We'll talk about what causes infants, fetuses, and death in the perinatal period. A little bit about mortality in children, the differences in child mortality in different ages, and where children die in America. Understand that in the past 100 years, childhood death has become unexpected. For example, earlier in the 20th century, about the infant mortality or childhood mortality rate was about 30%, or 100 in 1,000. So everybody experienced with a rate like that. In 1999, there's 7.1 in 1,000 children died. Is that correct? Or the mortality rate has dropped significantly. So it's no longer expected that a child will die here. And the leading causes of childhood mortality have changed. In 1900, infectious diseases was probably the leading cause of childhood mortality. And if you compare how many adults in various age groups, and the total deaths in 1999, you can see what a small proportion of those were pediatric deaths. So people are much more used to having adults die than children. I'll give you the percentages. I couldn't figure out how to put them in on a little graph. The leading cause overall of pediatric mortality is accidents and injuries. Okay, and that accounts for about 22%. The next most common cause is homicide-suicide, and that's about 11% of pediatric deaths are due to homicide or suicide. Prematurity, short gestational age, you can see there, is actually pretty common. I think it's probably around 8%. Cancer deaths, remember mortality from cancer has changed significantly over the past 30 years, particularly for the leukemias and things like that. So that runs about 4 or 5%. And then finally, congenital anomalies, you can see, can account for quite a large number. We still see SIDS deaths, although since the Back to Sleep campaign, Pediatrics, that's actually significantly dropped. Right? In other words, to put the baby on the back to go to sleep has, and that simple advice, dropped the rate of sudden infant death syndrome significantly.
The big other?
Let me see.
Yeah.
Yes, other.
The other is like other diseases? Like
I guess diseases, and some number of infectious diseases, or I guess metabolic disorders, or I don't know whether they're in with congenital anomalies. I think the vast majority of congenital anomalies are either neuro or cardiac defects, but I'm not sure exactly what all of those are. But I have a reference if you want to look at it. Placental cord are things like abruptio placenta, damage to the placenta.